Well, so good evening and special thanks to Dr. Chauhan for putting me on projector and making life bigger than the reality. So I think he has the record number of CMEs, and today is again DPP-4 inhibitor. So first disclaimer is that I am not an endocrinologist, not a diabetologist, but I am a cardiologist. So I just saw that we need to speak on cardiac benefit of the DPP-4 inhibitor. As you would know that recently there is a lot of emphasis on molecules which are cardio-friendly, so do not increase the cardiovascular adverse outcome. So we'll be briefly discussing the problem of diabetes and then what are the cardiovascular benefit of this molecule, why should we treat diabetes, and we should go away from glucocentric approach to a cardiocentric approach in these patients. And we'll also look at the guidelines, what do we say, and the summary about that. The problem is humongous. If you see, there is an estimated 537 million adults between 20 to 80 years are living with diabetes. So it's a big global problem, but in India in particular, we call that Indians are, or India is a diabetic capital of the world. So, when I was in UK, we saw a lot of Chinese people who used to come. They had, incidence of diabetes was very high. But the problem in our country is that we have got not only highest number of diabetes, but they are also very young. So people who are in less than 50 years of age group, the maximum number of diabetics are there world over. So if you see, this is the distribution of this problem, and you can see the India is right there, where the incidence of diabetes is pretty high. So every 10% of the population across the globe is suffering from diabetes, and Southeast Asia, simply because of the genetic profile and also our dietary pattern, probably this incidence is very high. And as we are growing from, as in last Independence Day speech, Prime Minister Modi said that by 2045, we have to be, in next 25 years, we have to be, something like developed nation. And this is the price which we are paying. That more and more people, and that's a global gap when you go from developing nation to developed nation, that journey takes a lot of burden on the citizens, and the diabetes is one of them. The number of people with diabetes in adults by age group in 2021, an estimated prevalence across the age group, this is the black line, you can see it's ever so growing. So definitely, as the age increases, more and more diabetic people would be there. So if you look at the diabetes and risk of cardiovascular events, that's quite evident, and we always say that diabetes is stage 1 cardiovascular disease. So those who are even pre-diabetic, the risk of cardiovascular complications are significantly higher when you compare with people who are non-diabetics. So definitely, the diabetics and pre-diabetics would not match the non-diabetics at any point, and the microvascular and macrovascular complications are significantly higher, and that is why the cardiac complication is in forefront. The reason being that 62% of the people with diabetes, they'll die of cardiovascular causes than any other disease. So definitely diabetes is something which is in the forefront, and as a cardiologist, we used to send all these patients to diabetologists, but now we have got, we are away from the what we call glucocentric approach. We need to look at with what molecule we treat our patients with diabetes, so that the cardiovascular complications are significantly lesser. And one of the major important factors is that we don't want the glycemic variability. Too higher sugar or too lower sugar, hypoglycemia would increase the risk of cardiovascular complications. And we have seen that any significant hypoglycemia would result into acute coronary syndrome and heart failure hospitalization. So we need to get away from that. So we need molecules which are safe and do not cause hypoglycemia. If you look at the HbA1c mortality association, definitely as the sugar control becomes poor, the excess mortality is associated with HbA1c concentration above 5%. So definitely as the HbA1c goes high, the mortality and cardiovascular complication goes significantly higher. So if you look at the diabetic control on long-term complications, as the diabetic duration increases, reducing the risk of complication becomes more difficult, meaning thereby that the number of years the person lives with diabetes, the complications are significantly higher. But definitely, if you see the better the control, the lesser the complication would be. But again, it's not only the control of sugar, but what molecules you use. And Dr. Chauhan in the beginning said that there is a revolution after 2015. Once we had access to SGLT2 inhibitor, then GLP-1 receptor analog. Now we have got and DPP4 inhibitor, because we need something which are, so DPP4 inhibitor is something. So if we look at the paradigm, that is like sulfonylureas where they increase the risk of cardiovascular complications. Then we have DPP4 inhibitors, they were by and large neutral, and the risk of hypoglycemia was significantly lesser, and in fact not there significantly. And then we have SGLT2 inhibitor and the GLP-1 receptor analog, where the cardiovascular mortality benefit was there. So that was something very, very unexpected, but that has really changed the scenario the way we manage the diabetes. So if you look at the UK PDS, 35 years data, every 1% fall in HbA1c reduces the complication in newly diagnosed type 2 diabetes mellitus. So we cannot go away completely from glucose-centric approach. So we need to control the HbA1c, but we should not be very, very strict. So if the the blood sugar control level, the HbA1c is less than 7, then we are happy that okay, the job is done, and then we say that the risk of complication has to come down. But there are molecules where at whatever the HbA1c level is, if you add those molecules, the risk of complication and mortality goes down significantly lesser. So if you see the dysglycemic legacy, meaning thereby that if somebody was in dysglycemia, the effect would go on and on for, so this was the data from almost nearly 6 years follow-up. And that clearly showed that the HbA1c, which was 8.1, you can see that the graph showed that the higher HbA1c level patient, even if the sugar is controlled, then they continue to have adverse event of the legacy continues, and that is what we have seen in post-COVID period also. The patients who were put on steroids and all, their blood sugar, those who are non-diabetic, they had to be put on insulin because the steroid and COVID infection, but the complication continues. So we see that the attrition rate of cardiovascular event rates are significantly higher, even after 1 year or 2 years of COVID infection. So meaning thereby that sugar, and that is why if you see what we call pregnancy-induced diabetes, there also the risk of complication was significantly higher than patients who were non-diabetic. So legacy effect is very, very important, that you should never ever allow the blood sugar to go significantly high. So if you look at the early glycemic control and the diabetes and aging study 2019, there also the outcome of study that the incidence of future microvascular complications, that is, end-stage renal disease, advanced eye disease and amputation, and macrovascular, so stroke, heart disease, heart failure and vascular disease event and the death, all these things. So microvascular is something where the renal disease is there, eye disease and amputation, and macrovascular is the bigger arteries where the heart, brain, stroke, vascular disease are there. So if you see there that the microvascular complication, if you see we compare to HbA1c less than 6.5 versus more than 6.5, so that is why we say that the golden number is 6.5%. If it is less than that, you can see that the microvascular event, when you compare that those who have had more than 6.5, the risk is 121% for microvascular complication in those patients who have got HbA1c more than 6.5, and macrovascular is again 48% higher, those who have got an HbA1c more than 6.5%, meaning thereby that we need to strictly control the HbA1c and mortality. So hardest endpoint is the mortality, and you can see that that's again 32% higher than the baseline. So the conclusion was that in newly diagnosed type 2 diabetes with more than 10 years of survival, HbA1c level more than 6.5 for first year after diagnosis was associated with worse outcome. So meaning thereby that if you add 1% increase in HbA1c level, there will be increased significant problem, and immediate intensive treatment for newly diagnosed patient may be necessary to avoid intermediate long-term diabetic complication and mortality, meaning thereby that So in our country, there is a lot of inhibition in starting the treatment. They would say that probably I'll control with diet, I'll control with exercise and all, but you need to control the initial blood sugar level, no matter how you control it, whether it is lifestyle or drug or combination of both, which is the best way. So when coming to the GLP-1 receptor analog and incretin-based treatment modality, you can see that the GLP-1 receptor analog and SGLT2 inhibitor has really come a big way, but the whole focus of insulin is pancreas, because that's the place where from the insulin secretion would come. So till now the sulfonylureas were something which used to increase the insulin secretion from the liver, but we need to go away from that, and then the insulin supplement is there. So GLP-1 receptor is something which is very, very important for release of the insulin. But we are talking about the DPP-4 inhibitor. So inhibition of DPP-4 is to increase the active GLP-1. So that is how it would work. So it will increase the active GLP-1 and increase the, that is how it will control the blood sugar levels. So DPP-4 inhibitor binding to DPP-4 enzyme. So there are multiple binding sites. We have got right from S1, S2, and S2X and extensive. So this is the binding of that enzyme, and with that the effect of blood sugar control would come. So sitagliptin binding with DPP-4 is stronger than either vildagliptin and saxagliptin, and that is why it has got a much robust glucose control. So clinical evidence with sitagliptin, theoretically it should work better than the other gliptins, but when you look at the sitagliptin as a monotherapy, 18 weeks of therapy decreases the HbA1c by 0.6%, 24 weeks would decrease it by 0.8%, and longer the duration, 18 weeks, there will be 1.2%, and when you give for more than 24 weeks, almost 1.5% reduction in HbA1c will be there. The rapid reduction of plasma glucose, sitagliptin monotherapy is something which is really good. So most of the time, people give sitagliptin and metformin combination because the risk of hypoglycemia is lesser, the glucose control is better. So that is what the intention is, that we should not induce any hypoglycemia. So within 24 hours after initiation of therapy, monotherapy, average blood sugar was decreased from baseline by almost 20.4 milligrams per deciliter, meaning thereby that it is a very robust agent to control the sugar. So how is sitagliptin efficacy compared to sulfonylureas? Because till now, till I would say 2010, the sulfonylureas and the insulin were the ruling the roost, so as far as the diabetic management were concerned. But this has really made huge difference. So sitagliptin is more effectively achieves a composite of endpoint of HbA1c reduction, lack of hypoglycemia, and no body weight gains. Because one of the problems with the diabetic patients was that with the insulin also and sulfonylureas also, there was a problem of weight gain, and then the patient would go into vicious cycle of weight gain, uncontrolled blood sugar, and so on and so forth. So basically, this is a molecule where the freedom of going into hypoglycemia is there, freedom from weight gain is there. So obviously that vicious cycle is not there at all. So if you see 85% lesser episode of hypoglycemia with sitagliptin, and at one point in time, till we had access to SGLT2 inhibitor and GLP-1 receptor analog, we considered that sitagliptin is really a wonderful molecule. It is still a wonderful molecule, and that is why it is being written the most common prescription when you see the anti-diabetic treatment in mild to moderate disease. So when other therapies fail, is it sitagliptin effective? Because it has got a different way, different mechanism. So sitagliptin has significant HbA1c reduction after metformin or pioglitazone failure. So if these molecules fail, then that's the reason why we have got combination of metformin and sitagliptin. And you can see that once this fails, with this you will have a significant reduction in blood sugar as well. So 3.5% in patients who completed this study without baseline of 11.2%, and fasting plasma glucose reduction was also significantly there, and also postprandial reduction was there. So meaning thereby that not only the 3 months average blood sugar is controlled, fasting and PP is also controlled. So what about long-term data? So initially people said that probably long-term sustenance would not be there, but if you see the sitagliptin and metformin long-term combination, again the patients were still target level reaching at after 2 years, and in 2 years sitagliptin monotherapy was found to be very effective. So meaning thereby there is no what we call tachyphylaxis or fatigue from the treatment, and sitagliptin and metformin combination proved to be very effective option in these situations. And you can see in 4 weeks, if still the patient would have significant reduction in HbA1c level and the blood sugar control. So long-term sitagliptin is associated with good efficacy, including as monotherapy with no additional safety concerns are there. So I get a lot of patients who come to me say, doctor, I've been taking this molecule for last 8 to 9 years, and would you like to change because now there are new molecules have come. So I say that you are doing absolutely fine because obviously they have invested in lifestyle modification as well. So you can give it for years together if the blood sugar control is very good and the patient is adhering to lifestyle modification and HbA1c level is less than 7 or more specifically less than 6.5. So coming to the cardiovascular safety data, there were trials, TACOS trial where this is a trial which is obviously, as Dr. Chauhan said, it's an older study, but when you see the sitagliptin does not appear to increase the risk of MACE, hospitalization of the heart failure or other adverse event, whereas there was data from SEVER-TV data which showed that with saxagliptin there was increased hospitalization of the heart failure. So this is a group of DPP4 inhibitor where the cardiovascular neutral adverse event neutrality is there. So neither the MACE event rate goes high or hospitalization of the heart failure is also not high. So that's why this is very important. So it's a TACOS trial after the SEVER trial was really that could be, because initially people were saying that we should not be using the DPP4 inhibitor in cardiac patient, but once the TACOS trial data came and the subgroup analysis of even the SEVER, there we saw that it's not something which is to be worried about. The rate of hospitalization for the heart failure did not differ between sitagliptin and placebo, and the incidence of severe hypoglycemia, infections and death from infection did not differ between the sitagliptin and placebo treatment groups. So meaning thereby that it is a fairly safe drug. In the sitagliptin group, HOMA-B values were reduced baseline, significantly improved within 24 hours and increased throughout this study, meaning thereby that the adverse events of this will be lesser. So if you look at the sitagliptin versus where does it stand compared to other DPP4 inhibitors, so why people choose sitagliptin as a preferred choice. So if you look at the sitagliptin's strong DPP4 binding was evident from the fact that other suggestion of the therapy, sitagliptin kept the DPP4 inhibitor for a considerably long time, and that is why it has got a, when you compare with the vildagliptin or saxagliptin, sitagliptin percentage of inhibition of DPP4 receptor was significantly better. So almost 94% DPP4 inhibition was there, and that's the reason why it is most effective DPP4 inhibitor. Also, when you compare the sitagliptin with other gliptins and see the percentage of DPP4 inhibitor, sitagliptin has got highest, almost 97% inhibition rate. So that is why it is something which is really good. And when you look at the cardiovascular safety trials, definitely the sitagliptin is something which ticks the box. So sitagliptin is non-inferior to placebo in reducing the MACE and hospitalization of heart failure. Other molecule which really comes very close to it and which Dr. Chauhan is very fond of is linagliptin. So linagliptin is again non-inferior of a composite of cardiovascular outcomes. So these are the two DPP4 inhibitors. As a cardiologist, we don't like tenagliptin because of the the risk of polymorphic VT and long QT syndrome and all, but definitely the safety profile of these two DPP4 inhibitors, that is sitagliptin and the linagliptin, is very good. So if you see the HbA1c reduction, sitagliptin versus vildagliptin and linagliptin, more patients achieve HbA1c reduction for more than 1% with sitagliptin compared to vilda and linagliptin. So the reason being that you can see almost nearly 42% patients with sitagliptin got more than 1% HbA1c reduction. HbA1c, when you compare sitagliptin with tenagliptin, because tenagliptin is a cheaper molecule and is very popular in our country, but if you see the comparison, the sitagliptin is again much more robust compared to tenagliptin, and postprandial glucose reduction, sitagliptin, was much better, because in Indians the major problem is that the postprandial glucose is high because of our dietary pattern and the genetic profile. So that is why it is an important molecule for our country also. When you look at the vildagliptin comparison, again the adverse events are significantly lesser with sitagliptin compared to the vildagliptin, though they are not really high. So what does the guidelines says in the diabetic management? There is a very famous slide where we had discussed many times that those who have got high blood sugar after monotherapy with metformin, we can add on DPP-4 inhibitors. So that's always in dual therapy, triple therapy, and a monotherapy also. So definitely this molecule has got a place in guidelines as well. So you can see that higher the blood sugar level, the more the scope of writing this molecule. So even the RSSDI clinical practice recommendation for the management of type 2 diabetes 2020, again it places DPP-4 inhibitor very closely and up in the chart. So definitely this is a molecule which should be given not only for its efficacy, for its cost benefit ratio, and also the cardiac neutrality, so cardiac friendly drug. So to conclude, friends, ladies and gentlemen, I would say that type 2 diabetes patients need all round glycemic control to prevent long-term cardiovascular event. So there will be two ways of decreasing. One way is to decrease the HbA1c level, and second is that it does not adversely affect the and causes hypoglycemia, and also has got a cardiac neutrality. So early is the glycemic control, the long-term, the glycemic durability can be achieved. And sitagliptin is an unique DPP-4 inhibitor with highest DPP-4 enzyme inhibition, and sitagliptin has shown efficacy in improving the glycemic control over long term, and it has also have a long-lasting nephroprotective and islet protective effect of patients with type 2 diabetes. So I think given these virtues of this molecule, we should be using it more often than not, and most importantly, with Zydus coming in with loss of patency of this molecule, it has become cheaper, so it is much more cost effective than it was there a few years back. So thank you very much for your kind attention, and I think you can direct your questions to Dr. Chauhan, because he is a diabetologist in this forum.
Sir, thank you very much for a masterly presentation. Despite starting late, we have finished in time, sir. You have a lot of time for interaction, Dr. Tulsi, sir. I think we have had a wonderful synopsis of DPP-4 inhibitors usage in diabetes. We have traveled the journey of DPP-4 inhibitors right from its inception in 2007 with sitagliptin, the first DPP-4 inhibitor to be launched, and where we understood a few things with DPP-4 inhibitors. The first one was, which sir pointed out so nicely, the incretin effect. And we know that this incretin effect is blunted in type 2 diabetes. And DPP-4 inhibitors aim to correct that. Okay? We will not go into the details of incretin effect right now, because it will take a lot of time, but incretin effect is one thing which is being addressed by DPP-4 inhibitors. For the first time, any anti-diabetic molecule was shown to decrease blood sugar in an insulin-dependent fashion. Okay? So, if you decrease your blood sugar to a particular level, what happens is two pathways are triggered. One pathway is that the DPP-4 inhibitors go and stimulate the glucagon pathway, so that it can go and then release glucose from the liver. It can cause glycogenolysis. Also, at the level of beta cells, what it will do is, it will down-regulate the beta cells so that they do not produce more insulin. Understand? So DPP-4 inhibitors principally have two actions, and sir said their basic action is to increase the active GLP-1 level. What does the active GLP-1 level do? It goes and acts on the beta cells and increases insulin. Okay? It also goes and acts on the glucagon axis and affects glucagon axis favorably, so that ultimately what happens is that if your sugar goes below a certain level, then the insulin secretion is stopped and the glucagon secretion is activated. So For the first time, these actions, they are being done in a glucose dependent. What is your blood glucose in that level? No other molecule does that. You know that what sulfonylurea does? Okay? They will decrease blood sugar and cause very severe hypoglycemia, at times necessitating a hospitalization. There have been a lot of studies on a lot of DPP-4 inhibitors, and Sitagliptin, since it was the first one to be launched, has come under scrutiny multiple times. Sir, Dr. Viveka sir, I would like to ask you the first question on its renal issues. We know that we had a lot of DPP-4 inhibitors after that, wherein we had wonderful benefits on that front. One of the criticisms of DPP-4 inhibitor Sitagliptin has been that we need to continually moderate the dose of Sitagliptin once the eGFR goes on decreasing, which happens in every type 2 diabetic. So your comment on that, sir?
Yes, I think except for linagliptin, the other DPP-4 inhibitor, we need to titrate the dose if the eGFR goes down. So that is something which is important. So only one DPP-4 inhibitor is there where we don't have to titrate the dose accordingly.
Sir, my second question on Sitagliptin is, you said that it decreases the DPP-4 to the maximum level. Whatever the DPP-4 inhibition, whether it is linagliptin or it is Sitagliptin or it is hexagliptin or any other gliptin, the HbA1c reduction is always to the tune of 0.5 to 0.6%, never more than that. So they are very, very mild hypoglycemic agents. Why should we at all use a mild hypoglycemic agent, especially when they are mostly cardiac neutral and no demonstrated cardiac benefits as compared to other benefits? Why should we use such costly molecules? Your comment on that?
Yes, I think it's no longer a costly molecule. Now it has become cheaper. The second thing is that one important property of this molecule is that the hypoglycemia is not there. So that's again a big boom. The third thing is that in combination with metformin, it is a really good hypoglycemic control is there to the tune of 3.4% reduction in HbA1c there. And the longer the use, the more reduction in HbA1c there without the risk of causing hypoglycemia. So you can see more than 2 weeks if you use, the risk of decreasing the HbA1c level was to the tune of 1.3% to 1.6%. So meaning thereby that if you use for longer and combine it with metformin, then probably the HbA1c level would be significantly lesser. But the best of the I think which is there that with patients who are you could see in Tecostral also the patients who were on heart failure patient hospitalization did not increase. Even if you look at the cardiovascular outcome, coronary events, that also did not increase. So you need a neutral molecule. So the patients who have not an established cardiovascular disease is the molecule to latch onto, so that you don't give them hypoglycemia and hypoglycemia induced adverse cardiac event. So it's just like it's like once you start it, just keep on monitoring sugar. You don't have to really bother about the risk of hypoglycemia. That's an important property of this molecule.
Sir, you mentioned a slide just in the end of your talk, which said that there are now recommendations from RSSBI practice guidelines and from European recommendations, American recommendations. If the HbA1c is more than 7.5%, dual therapy. If the HbA1c is more than 9%, triple therapy. If I get a patient today who does not have any cardiac issues, no heart failure, nothing, what should be my 3 medications to start this patient on if his HbA1c is more than 9%?
Yes, I think there are 2 groups of patients. One is naive, who is not. So the problem with our country is that many patients do not know that they have diabetes. So we see that a lot of patients who come with acute MI, for the first time they come to know that they are diabetic. Blood sugar is high, they are in fact in diabetic ketoacidosis, and they are still saying that we are not diabetic. So meaning thereby that if they are not on any anti glycemic drug, then definitely the HbA1c will keep on piling, and you'll be surprised that even with the DPP4 inhibitor and metformin, they would over the period of time, maybe in 3 months' time, the HbA1c level from 10.5 or 11 would come down to almost less than 7. So naive patients, we need to start at a lower dose. We should not be really pushing them hard with the multiple drug choices. So I don't agree that we should go with 3 in naive patient, 3 anti-diabetic medication complication. As a cardiologist, and you must have seen that I prefer the DPP4 inhibitors with SGLT2 inhibitor if the patient is obese, or now if they have got atherosclerotic cardiovascular disease, risk calculation shows that risk is more than 10% annual, then we should be putting them on GLP-1 receptor analog. So I would prefer these in patients who are having high atherosclerotic cardiovascular disease. So those who have got atherosclerotic cardiovascular disease, GLP-1 receptor would be as a number 1 choice, and then DPP4 and SGLT2. But those who have got heart failure of any kind, be it preserved ejection fraction or reduced ejection fraction, will be using SGLT2 inhibitor as a number 1 drug, and then rest would follow.
Sir, your talk was wonderful, and I was looking for one contraindication to the use of sitagliptin. I found none. Is there actually any contraindication of using sitagliptin?
Apart from insensitivity, the
sensitivity, hypersensitivity
to that molecule, I would say that it's very so one of the most patient-friendly molecule.
Right. Thank you. Over to Dr. Tulsi, sir.
What a great talk again, Dr. Viveka. So, most of your patients would have augmented ASVD. So, what's the role of DP4 inhibitors in those patients who have augmented ASVD?
Yes, I think initially, as we said, that till 2015, we did not have anything other than the DPP4 inhibitor. And now in today's world also, those patients who cannot afford, because remember the price is a big barrier in any part of the world. So in those situations, it's a better bet than sulfonylureas. But those who can afford, we always switch them to GLP-1 receptor analog or SGLT2 inhibitor. But as Dr. Chauhan was saying, that the recommendation is also there that if the blood sugar at HbA1c level is higher, then we should combine these 3 together.
My second question, Dr. Viveka, would be, most global cardiology guidelines say use drugs which have cardiovascular benefits, which have renal benefits. So do we have cardiovascular benefits and renal benefits? Renal benefits surely because of the Carmelina trial, which said it reduced albuminuria here. So I'm not too sure about the TCOS trial. Did they say it reduced albuminuria?
No, so it did not say.
So, but the TCOS trial was published in Lancet, and it said that this CETA seems to be the safest CV profile. So, is it because of what? Why would CETA have a safest CV profile? Would it be because it has, we can hypothesize that there is a differential selectivity between DP4 inhibitors for non-GLP-1 substrate that somehow tilts the balance towards CETA. What do you say, sir?
Yes, I think that's a real valid explanation, and neutrality is also very important, and I would say that by virtue of not inducing hypoglycemia is again a big virtue of this molecule. Hospitalization due to heart failure does not increase. So I think the safest bet apart from insulin in these situations would have been the sitagliptin. But now the story is different. The Carmelina and all was with the linagliptin. So definitely today we are talking about sitagliptin. So it's something which is it really brought the fear out of physicians that the SAVOR trial, which showed increased hospitalization with heart failure with DPP4 inhibitor, that was negated by this molecule. So that's the importance of this. And then also, being a cardio neutral is also important, that you achieve the reduction in blood sugar, but you don't induce any adverse cardiovascular event. So, and then one of the biggest things which I admire as a cardiologist, that it will not cause increased events. So that's again an achievement.
So,
Can I just interject
sure,
for a minute?
sure.
Sir, it's not only about DPP4 inhibitors that they, despite doing the same thing, the same inhibition of enzymes, their selectivity for the different enzymes vary, and therefore the results may be different. Same is true for SGLT2 inhibitors. Just one line, sir. You know the EMPEREC trial, you know also the CANVAS trial, and you also know the trial with empagliflozin. Just see that what is happening with empagliflozin. It is reducing MACE. It is reducing hospitalization because of heart failure. It is decreasing cardiovascular mortality, morbidity, overall death. What is canagliflozin doing? It is decreasing HHF. It is also decreasing MACE, but that decrease in MACE is not being translated into decreased cardiovascular death. As what? Just a minute. As is being witnessed with empagliflozin. What is happening with empagliflozin? It is decreasing HHF almost in fact better than the other molecules, but is not decreasing MACE and is doing nothing on the front of cardiovascular mortality morbidity. And then comes empagliflozin, which is only decreasing HHF, nothing on MACE, nothing on cardiovascular mortality morbidity, nothing on overall mortality. So the molecules, despite doing the same thing, differ in their cardiovascular benefits. I was just wanted to bring home that point, sir. So same thing is with DPP4 inhibitors. Despite Carmelina, sir, and despite Carolina, we still do not have much to choose between the two molecules, except for the fact that if patient has got CKD2, CKD3, you have to be very careful with sitagliptin and start down regulating the dose. Your next question, sir.
Wonderful. Very well explained, Dr. Chauhan. So, Dr. Viveka, so red flags were raised with the Savior TME53, with Sexa, and with the Examine, the what was that?
Allogliptin.
See, so now, but when they compared, see, recent meta-analysis, when they compared, they said, probably not so. There aren't many red flags. See, Sexa would probably cause increased heart failure hospitalization by about 3.7%, as would placebo cause by about 2.8%. So isn't much. So probably red flags. Was it a defective trial? See, we are not sure. But probably DPP4 inhibitors, if you don't have prior history of heart failure, and if you don't have CKD, probably they're safe to use. What do you say, sir?
Yeah, so I think if you see the guidelines also, now they say that you need to be, you don't have to withhold in those patients, so it does not increase the heart failure. So it is at worst just neutral. It will not give you additional benefit, but it will not worsen the heart failure. So that is what subgroup analysis of Soviet TB23 also, and that doubt was cleared by Technos trial.
Right. So, Dr. Chauhan, see, during the COVID days, they said sitagliptin reduced heart failure hospitalizations, not only heart failure hospitalization, hospitalizations to ICU, to probably reduce mechanical ventilation as well by a whopping 87% as compared to insulin. See, how did they do that? Was it because of the ADA, not the American Diabetic Association, but because of the adenosine deaminase activity, which caused increased T cell proliferation and increased immune cells? What do you say, Dr. Chauhan?
I think you explained it already, sir. I think you may explain it further for us.
That's it.
You may explain it further for us.
So,
kindly explain.
So, what they observed was, of course, it was not a big, large-scale study. They said they noticed that people who were given DPP4 inhibitors, especially Sita, see, it decreased hospitalization, it decreased ICU admissions, it decreased mechanical ventilation by a whopping 87%. Because because of the ADA, the effect on ADA with DPP4 inhibitors, ADA is adenosine deaminase activity, which causes increased T cell proliferation. As we know, if you have increased T cells, your immune cells probably are better. This was compared with the patients who are on insulin. That's it.
Was there any suggestion of using Sitagliptin even in non-diabetic population to achieve this?
I'm not sure about that. They never used it. Probably it's to be used because this is incretin based. How can you use this in non-diabetic, sir?
No, I'm just asking, sir.
No, I'm asking you a further question. How can you
I
use
don't
this?
know. I am a novice on this, sir. I am asking you because
You
asked
just
about
cannot. It is incretin based therapy. How can you use it?
you have asked a wonderful question, sir, and I wanted a answer which I don't know. And I have to be frank, sir. I don't know. There is no harm in saying I don't know.
You know it all. You're just pulling my leg. Okay, so Dr. Chauhan, what about see in NODAT? See any effects on NODAT?
What is NODAT, sir?
So NODAT is new onset diabetes after transplant, liver transplant or kidney transplant. When you give this DP4 inhibitors,
Same effect as in non-transplanted people. There is no difference.
so
There is no difference in HbA1 efficacy
no sir. So when you get new onset diabetes
after transplant.
after transplant,
Yes.
this is the drug to be given.
DPP4 inhibitor.
DPP4
That is what I
inhibitor.
am saying, sir. There is no difference in the HbA efficacy of DPP4 inhibitors transplanted versus not transplanted in new onset diabetes after transplant. Same efficacy.
So there's a new indication. What about in PD,
What is PD, sir?
Parkinson's disease?
I don't know, sir. If there is any role of.
So it increases dopamine.
No, but is there any clinically beneficial use? Do they increase the dopamine levels?
That's
to such
what
an
they
extent?
said. A study said that increases dopamine. So
In diabetics or non-diabetics?
in diabetics.
Okay, sir, I am
How
not
can you
aware.
give this drug in non-diabetics?
Come
sir?
on,
Again,
Dr.
are
Tulsi, you can give it anywhere, sir. You can give it anywhere, sir.
No, sir.
Okay, anyway. Jokes apart, sir, I am not aware whether they are being used for Parkinson's disease in type 2 diabetes and whether they can actually clinically significantly raise the levels of dopamine for beneficial levels. I am not aware.
What about NFLD?
Sir, NAFLD, the only drug which has been shown to be effective, the anti-diabetic molecules, let us revise it for everyone's benefit. Metformin. Number 2, pioglitazone. Number 3, SGLT2 inhibitors. There is no role,
GLP-1.
yes, GLP-1
Yes,
analogs, yes, GLP-1 analogs. But again, the three commonly used ones which are orally available are these molecules. The other molecules have not demonstrated anything else, any benefits.
So they said probably reduces NFLD as well. And
Which
last,
molecule? Which? All the DPP4
all
inhibitors?
DP4 inhibitors.
Sir, I would put it the other way around. I would put it the other way around. Which DPP4 inhibitors you can use in hepatically compromised people? And there are two molecules which can continue to use even in any scoring of child-poor. And one of them is linagliptin, another is sitagliptin. To be very, very surprised, we do not have any studies on vildagliptin. Actually, it should be avoided in severe hepatotoxicity. Teneligliptin should be avoided. No studies on hepatotoxicity. And the third one, sir, which you said, the sitagliptin, it has to be moderated. In moderate to severe hepatotoxicity, only 2 DPP4 inhibitors can be given across spectrum of any hepatotoxicity. One linagliptin, another sitagliptin. Okay, sir?
So lastly, Dr. Viveka, the ACC followed the ADA like Mary's lamb for the past 4 consecutive years. That's a big thing, sir. Thank you, sir.
Sir, take a breath, sir. Can I ask my light questions, Dr. Viveka? Sir, पानी वानी भी पी लो, इन्होंने थोड़ा थका दिया होगा। So I will start my. Sir, ये इतना जोर जोर से बोल रहे थे. How can you use in non-diabetics DPP4? You have been. No. I'm not saying. I will go step by. SGLT2 came for diabetes only. Now then, you have been using with studies heart failure without diabetes. There have been GLP-1 came for diabetes, now for weight reduction. So I'm saying.
Please tell us how you can use DP4 inhibitor. These are incretin based molecules. How can you use?
Okay.
In type 1, tell us.
SGLT2 is different in different conditions. How? It doesn't work on SGLT2 receptors?
I think it is,
Okay,
it is sir, with due respect to both the masters, I think it is subject for discussion. We
Yes.
will get back after,
I am saying,
after having considered all the aspects.
Sir, I am saying there are so many things.
Yes,
Metformin started as anti-influenza medicine.
absolutely.
So
sir.
how could one change it will be anti-diabetic?
Yes.
Digoxin came for a gynae use. It was for heart failure then. So things have come in a different way, and he was promoting rosuvastatin after every surgery. If you remember, statins,
It has,
because
it reduces AKI.
so similarly, sir, this may also be, we are learning.
You are
Sitagliptin,
now canagliflozin 300
Sure.
milligram dose being recommended for obesity
Yes.
by FDA. By FDA.
indications do change when we find newer things.
Ah.
There was a reference for
As I said,
COVID and
and I submit humbly, sir.
Sir,
We will
sir.
get back on this topic.
Sure,
after
sir.
we have said it. Sir, your question.
मैं वही सवाल आगे मेरे को पूछने तो दो. Even in Middle East respiratory syndrome,
Mars.
DPP4, they were found to be effective.
Okay.
They were found to be blocking the attachment of respiratory epithelium with the virus. So this was known because they are also acting on the DPP4 enzyme. So DPP4 enzyme is required for the attachment.
Any trial? Any trial?
It was noted.
Okay.
So
It was just
the
an
same way,
observational study.
same observation as the ICU admissions and all this were less with DPP4, Sitagliptin was probably the most common. So, Badacha Badalambra, Sexa, I really feel bad for that. Same for Rosie. They were really not bad. I have seen third umpire giving wrong decision at times. So coming to my questions, sir. These were para questions. Firstly, sir, diabetes and hypertension. Do they differ in male and female? Number one. Whether diabetes and hypertension, diabetes and heart problem. How many diabetics females will have heart problem versus male?
So, in fact, the females would have more comorbid condition to have a heart problem compared to the male. So, male being a male age more than 45 itself is a risk factor for having a heart problem. So, definitely, if the male would get a diabetes, then they are having much higher risk of cardiovascular disease. But when you look at the absolute number, in females to have a heart disease, they have to have more comorbid conditions. So if they are having diabetes, high blood pressure and all those things, then the risk of cardiovascular disease is higher. Whereas in male, being a male itself with hypertension alone would cause increased risk of cardiovascular disease.
Incidence of heart problem in diabetic type 1 and type 2. Please elaborate, I have some doubts.
Yes, I think both so very fact of having diabetes is increased risk of cardiovascular disease. Both macrovascular complications are significantly higher, and even in patients who are type 1, there will be significantly increased risk of cardiovascular disease, and in type 2 we have already seen. So I would say that the less lethal problems are type 2 diabetes if they are well controlled, but type 1, because the very fact of being the increased duration of diabetes would put them at a higher risk of cardiovascular disease.
Because type 2 has insulin resistance and insulin per se is cardiotoxic, I think. Sir, last question, sir. Sir, आप non-striking पे हो, अपनी जगह पे रहो. The effect of GLP-1 on tongue. There was a mention about the effect on tongue. What is the effect on tongue? Tongue. T-O-N-G-U-E, sir, tongue. tongue पे भी एक इफेक्ट लिखा था सर आपके स्लाइड में.
No, so basically it causes
taste में फर्क होता है?
so it causes
इससे गुड इफेक्ट होता है.
no, so it
दारू
causes
पीने के बाद भी लोगों को अच्छा नहीं लगता पर अच्छा लग रहा होता है.
नहीं, so it causes distaste and also the anorexia and nausea, and that is one of the reason why it causes significant weight loss as well.
Sir, any questions, sir?
Sir,
What is the prevalence of diabetes in population aged say 75 to 85 as compared to the younger population?
Yes, it's significantly higher. I would not be able to.
So that's what I'm saying, that the people who who are surviving between 75 to 85, that means the diabetes has done nothing to them.
So basically, it is the severity of diabetes and duration and degree of uncontrolled diabetes also matters. So we have seen that. So that is what we tell a lot of our patients, that if the person has been diagnosed with heart disease, their lifestyle modification becomes very good. And plus they would control their risk factors very well. If somebody has got a heart disease, so we have seen many times patients who have got a cardiac event, they outlive their partners and friends because their lifestyle has become really, really good. So answering your question, that those who had an early diabetes, they were so conscious about their lifestyle, what they do eat, the exercise. So if you look at the guideline also, the exercise duration and the number of days a diabetic should exercise. In Indians it is all 7 days a week, for Westerners or Caucasians it is 6 days in a week. So if you follow the lifestyle modification and control the sugar less than 7 or 6.5, then the outcome will be better than people who have got uncontrolled lifestyle or diabetes. If the person has got HbA1c level of in last 5 years of nearly 10, and those who had 40 years of diabetes but HbA1c was in the range of 6.5, obviously they will outlive those people who have HbA1c is poorly controlled for 5 years. And there are multiple other co-variables like genetic history, the comorbid conditions, stress and all those things you can't really correlate, but definitely that is something where the multivariate analysis has to be done for so we have seen there are many patients who are diabetic, smoker, alcoholic and all, and they have lived Kushwant Singh and all. There are so many people who have lived for nearly 100 years simply because there are certain things we don't really know, but the average data shows that uncontrolled diabetes for longer would result into cardiovascular mortality.
Oh, actually, earlier when we were very young and somebody said 65-year-old, 70-year-old, we used to think they're very old people. But now once the resident tells us from ED, so the 70-year-old has come, so we think he's not very old. And now, a lot of patients are getting admitted in the age group of 85, 90, 95. We get an admission about 100 years of age, 100 plus also. Rather below 70, or somebody says 70, 69, even 75. We think कोई ज़्यादा age नहीं है. He get a chance to make it. And what I'm finding, majority of the admissions are 75 plus, 80 plus.
No, that's right.
And these patients have, I think it is difficult to find a patient that who is non-diabetic, non-hypertensive. I must be coming across only 2-3%. If you say, आपको है diabetes नहीं, डॉक्टर साहब गोली खाता. They are all. And in spite of that, if you go and take their history, most of them you are able to discharge. With whatever complications they come. If you treat, it is an occasional patient who dies, who is probably destined to die. But that is the reason I was saying that what is the prevalence of diabetes in this age group? Then whatever trials we are talking, mortality is this, itna बढ़ गया, itna बढ़ गया. I think genetics and the history of longevity of life, of family history has a lot to do with it.
Yes, I think if you look at the, on the Independence Day, there was data being out that one of the Twitter user had said that, the longevity or life expectancy at independence was 42 years for Indians. And now we have 73 years. So definitely with the increasing advancements and all, the life expectancy has gone up. In just 10 years, we have seen that patients who were at the age of 70, we used to say that you had a heart attack, you would need angioplasty or anything. They would say that, I've lived my life, I don't want all this. But now at the age of, so we did one of India's oldest TAVI inpatient who was 102 years. And he was okay, he said, I'm doing everything on my own, why don't I want to be independent in my life. At the age of 102, he was going for walk and doing normal activities. So I think you're right that, so before coming here, I was in Europe, and there also I saw, if you see the person who, even if he is 100 years, they would love to be independent. So they would not, they will feel offended if you give a helping hand that, okay, I'll hold you, please I'll support you in walking and all. So that's not something. So I think there is a significant change, and the definition of old is really changing. Now we say that 80 is now new 40. So let's see.
I would also like to pinpoint something, and this will be an eye opener for all of us. I referred a case, 66-year-old gentleman from South Africa to Dr. Viveka 2 days ago. This gentleman has had an angioplasty done in 2017, and even much before that, in 2015, he had a sudden problem with his legs, inability to walk, pain in the thighs and in the hips while walking, and he had a thrombus in the aortoiliac territory. He is not a diabetic. His HbA1c is only 5%. He is a smoker. So I referred this case to Dr. Viveka sir he said that we need to do an angiogram and we need to fix this up. Maybe he will require stenting. Sir did an angiogram. He has a 100% block in the aorta below a certain level, and then the further circulation almost all blocked. But since 7 years have passed, since then he has now developed collaterals. Incidentally, sir discovered that he had a LAD and 95%, which sir has stented. It is not necessary that the patient has to have diabetes for an accelerated atherosclerosis. There is, and sir, we discussed many times, Dr. Mangla sir, that it is the genes which are at play. You only told me that you have seen people smoking for 40 years, nothing happening to them. And there are people who have been smoking only for 10 years. They have developed a cardiac complication, they have developed a renal complication, and now they have developed a CA. So genes are playing a great role in this, and we have to understand that. And sir, being a cardiologist who is seeing all the complications, whether diabetic, non-diabetic, genetic, familial, so he understands it better. I would like this comment. What about accelerated atherosclerosis in the non-diabetic population?
Yes, I think that's an entity where the lipid level plays an important role. We have seen many non-diabetics who have got hypercholesterolemia or even familial hypercholesterolemia, and those are the people who would have significant, and then as Dr. Chauhan rightly said, we have seen the patient who has got strong families, both the parents if they are involved, then despite being non-diabetic, they would have significant early onset, what we call malignant atherosclerosis. And we have seen that it is all getting precipitated by inflammation. And best example or worst example, what we can say is, we have seen during COVID time that even young people in the age of 23, 24, we had to do angioplasty, and we saw that post-COVID their interleukin 6 and all was sky high. So those are the patients who are maximally affected. So inflammation because of anything, we see that people who are coming from background of mining or industrial exposure, those places where the heart disease and the atherosclerosis is significantly higher than patients who are coming from neat villages or places where the pollution is significantly less.
Dr. Mathur has a question.
It's not actually a question, it's a query to Dr. Chauhan. One of my patients, he is not suitable for metformin, not for the glycerin also. The only thing we are shooting is only SGLT. What else can be given to regulate the sugar level?
Good question, sir. You can give him oral semaglutide, sir, if the patient can afford.
No, I can't afford.
He cannot afford?
No.
Right. Sir, give him AGI, alpha glucosidase inhibitor. AGI, voglibose or acarbose.
Voglibose can be given.
Yes, sir. Voglibose can be given.
Along with SGLT.
Yes, sir. But you will have to explain to the patient that he might have little postprandial distension and maybe at times diarrhea.
Because the same problem she was having with metformin only.
Yes. Sir, let's with this combination. Sir, there is a subgroup of people who cannot.
Can sulfonyl urea. Now the problem is the SGLT2 is given in the morning and sulfonine urine, if I give in the evening, then the person will go for hypoglycemia.
Sir, give it in the morning and give SGLT2 in the night.
Can it be given in the night?
Yeah, just change the.
SGLT2 can be given in the night also.
Absolutely.
And sulfonine in the morning.
There is no contraindication of giving SGLT2 at night, sir.
Not for
There is
urine,
no contraindication.
excessive urine.
Sir, SGLT2 initially will cause a lot of diuresis, but once you continue to give, the diuresis, even the noxemia subsides.
I think that will be the best combination.
Absolutely, sir. Absolutely. There is, on that score, there is no problem.
Thank you.
Any other question? I will. Any other question? Anyone has? Sir.
Expectancy of life, we've been making a song and dance. About the expectancy of life, we've been making a song and dance and 15 out of it.
Only 5 more minutes. Only 5 more minutes.
2 minutes. क्या बोले चलेंगे यार?
बोलिए.
So the expectancy of life is better because IMR is reduced. Because see, if a person dies at 0 and at 80, average comes to 40. IMR has been very well controlled, so the expectancy of life is also that's a factor. Besides everything.
I think, can I just request Dr. Saigal sir, please, only 2 minutes. Let us summarize this wonderful CME for all of you while you enjoy your last time. I think all of you would agree that we had a wonderful CME with wonderful queries from Dr. Tulsi sir, Dr. Saigal sir, Dr. P.K. Mangla sir, Dr. G.M. Mathur sir. DPP-4 inhibitors have a great role in the treatment of type 2 diabetes. Please take home the message that we do not have makhan and malai in our clinics as far as diabetes is concerned. We are having people with HbA1c of 10, 11, 12, 13. We are not talking about HbA1c of 7.5. No, we don't get those patients. They come to us when everything else has failed, including Baba Ramdev. They have tried. Yes. Baba Ramdev, 2010, 11, 12, 13, 14, 15, 16, 17, 22 guidelines, everything has failed. Then they come to you, including their yoga and everything, the kind of exercise that they indulge in. Okay? So everything else has failed. Now they come to you. What is the HbA1c? 11%. What is their expectation? Miracle. In 1 month, HbA1c, American Diabetes Association standard. Doesn't happen. But please understand one thing. My parting shot to all of you. Higher the baseline, more is the HbA1c reduction. If you have a patient with an HbA1c of 11, sir, beautifully explained, the HbA1c is not going to be only 0.6%. It can be to the tune of 3.4%, especially with combination with metformin. Okay, so DPP-4 inhibitors have a great role in the treatment of type 2 diabetes. Innumerable trials have demonstrated their cardiac neutrality, their cardiac safety. They are a very good combination to combine with metformin, either as a first line with metformin or as a consequent to SGLT2 inhibitors. Now we have another option of combining DPP-4 inhibitors with SGLT2 inhibitors. Okay, so they have a great role. I want to thank Zydus Discovery Live team to sponsor this CME for all of us, and I want to thank Dr. Viveka sir and go in your honor sir to do so many CMEs for us. Dr. Viveka will be with us on 31st along with Dr. Sanjeev Gulati. Dr. Viveka sir will also be with us on 7th of September on a very new molecule launched by Pharmed, a drug called MGHT. The role of magnesium in hypertension. Sir will elaborate on that. We have a lot of doubts on that. Interjected by another CME on 24 by one of the another legends in Max by Dr. Pradeep Chaube and moderated by none other than our own master Dr. S K Chauhan sir. So thank you very much sir. And I now request all of you to please join for dinner. Thank you very much, everyone.